Good morning. Thank you guys for coming, and thank you to the organizers and to Rob for inviting me. This is a really large topic. This is a long presentation, but it's mostly pictures, which is good because I have a short attention span. So we're going to go through these, and I'm going to show you kind of where, like, how does liver-directed therapy fit in all this? Because when we think about patients that have neuroendocrine tumors, we have a toolkit as providers, and there's a lot of things we can do, right? And that's one of the great things about working with patients that have this type of cancer is that we do have some options, okay? And liver-directed therapy is one of them. So, but what is liver-directed therapy? It's sort of a difficult term to describe. So no disclosures. I want to sort of put it in context. I think context is really, really important. Because it gives us some, it's like, how did we get here? How did we get to liver-directed therapy? I thought I was going for a CT scan. What is this that we're talking about? And how is this different from getting scans of other types or tests of other types? So we'll talk about radiology sort of very, very briefly. We're gonna gloss over that. We'll talk about biopsy because I think biopsy is important. You guys as patients, you're all going to go through this. I want you guys to kind of get a sense of what it is. Maybe you've already been through it. Maybe we'll go through it again. But I want you guys to kind of understand it. And then we'll talk about IR and we'll work our way up to liver-directed therapies and we'll go through those. And we'll also touch on goals of care. So this is your multidisciplinary tumor team. It's just a bunch of Lego figures around a table. But it used to be like this, and it was great. It was a good time for us all to come together as providers and see everybody face to face and build relationships. Unfortunately, since COVID, a lot of these have gone virtual. I long for the day where we're all together again, but one day I hope. But we'll talk more about this team later. Other providers will talk about it. It's a lot of different folks, and everybody brings something to the table. They're all critical. So background. Radiology is a broad medical field. We are physicians that, and there's really two arms of radiology. There's diagnostic radiology and there's interventional radiology. The diagnostic radiologists interpret medical imaging to diagnose disease. The interventional radiologists, we treat disease. We also do procedures to diagnose disease as well. But we're all diagnostic radiology trained and dual board certified, so we got additional training in interventions. So interventions is to intervene in the course of disease, right? So we're not just diagnosing, but we're also trying to treat in many cases as well. Nuclear medicine is another field of radiology, and I'm not going to talk about that much today, but hopefully, I think you guys will hear some of that. So diagnosis. Imaging neuroendocrine tumors, Dr. Gupta talked about this a good bit, but it's critical to know how far has the cancer spread, right? That's how we can plan our treatments, and then how quickly is it spreading, how quickly is it growing. Every imaging tool has advantages and disadvantages. There are some common tools and imaging tools that you guys are probably already familiar with, CT, MRI, ultrasound, PET-CT. Every tool gives us a piece of the puzzle, okay? And so you may go for all of these and be like, oh my God, why am I getting all these tests? And it's because each one of these things does give us a piece of the puzzle. CT is great for anatomy, gets to look at a bunch of different tissues, but it doesn't look at the liver as well as MRI. MRI is great for the liver. And then ultrasound is real time, lets the provider sort of see exactly what's what and where it is, and helps me with procedure planning. And then PET-CT gives us some data about the physiology of the tumor, and so it's functional. So CT scan, this is what a CT scanner looks like. This is the one we have at VUMC, the one I do procedures on. And I spend a lot of time next to this machine. It looks like a donut. It's a place where you guys may have been before, but that's what it looks like. This is an MRI, also looks like a donut. It's a deeper donut. It's tighter, but this gives us really good images of the liver. It is a louder machine, but it takes longer to do the imaging. We don't do procedures often in this machine, but it's very important. This is an ultrasound. You've seen these before. I use these every day to do procedures, but they'll park this next to the bed, and we'll use it to do different things real time. PET-CT also looks like a donut. I love donuts. As an aside, Donut Den, very good in Nashville if you've never been. They didn't pay me to say that. I just drove by that on the way here today. So PET-CT is another tool, very important, but that's what the machine looks like. Very quickly, anatomy. We should probably we won't talk too much about this, but all of these tools help us see inside the body, get a sense of what's going on without cutting into the patient. Okay, so this is what a neuroendocrine tumor looks like. This is a pancreatic neuroendocrine tumor. You can see the 3 arrows. They're pointing to the pancreatic head mass. It looks like a sort of a brighter gray ball of tissue that should not be there. In the liver, we see these little white spots. Those are liver metastases. So this is a pancreatic tumor which is metastasized to the liver. Okay. And metastasis means that it's spread, is a tumor deposit that is away from the original site. So this is the primary tumor. This is a metastasis. Okay, each one of these little balls. So if you hear the terms primary and metastasis, that's what they're referring to. Let's see. Okay, this is a this is a tumor which is this is a metastasis actually from a distal small bowel tumor, and this is a very common a very common pattern of spread. You'll see a tumor in the distal ileum, and then that tumor sits there, but it metastasizes to a regional lymph node in the mesentery. That is the tissue coming out of the small bowel and going up towards the liver. And there's nodes there, and those nodes catch tumor cells, and the tumor cells grow inside those nodes. You end up with this. This is this little tumor mass there, but that is not the primary. That is a metastasis, and that's a very common finding in patients with neuroendocrine tumor. And when you see this on a CT scan, patient comes in with abdominal pain. When I see this on a CT scan, I immediately consider a neuroendocrine tumor. I mean, it's what I do, but this is also very, this is a common way these patients are diagnosed. They'll come in with abdominal pain and you see this. They may not have liver metastases at that time, but this is a big indicator. So we see this often. So this is one of our patients who's got liver metastases, has a high burden of disease, but you can see it best on this is what's called a DWI MRI. This is an MRI scan, or these are multiple sequences is what we call each one of these images. It's a sequence. It's an image taken in one period of time, right? So we're looking at a snapshot period of time. And the way these tumors behave is very important in how we kind of figure out what's going on. But that's what it looks like. And that's what an MRI looks like. Another MRI, we're going to skip it because we're going to cover a lot. This is kind of comparing a CT to an MRI. CT is up here. You see the bones real well. You see the tissues okay. But the MRI, I don't know if it's as obvious, but you see the what's going on inside the liver so much better. All right, this is a PET-CT. Each one of these black balls is a tumor. Unfortunately, this patient has tumors spread kind of throughout their skeleton, also in their liver, their chest. This is a somatostatin receptor PET-CT. So this is specifically looking at neuroendocrine tumors. But this is what it looks like. Another PET-CT. And this shows you kind of what the correlation is between CT and PET. So CT are the colorful, PET is the colorful images. CT is the gray images, black and white images, and they correspond to one another. They are fused so that we can kind of see where things are. All right, biopsy. So biopsy critical for accurate diagnosis, staging, treatment. How many people have had a biopsy? Okay. So a lot of folks. And did a surgeon do your biopsy, a GI doctor, or an interventional radiologist? Surgeon? Okay. So a lot of times, yeah, you'll get tissue at the site at the time of surgery. And then sometimes if surgery hasn't been done yet or they're trying to establish metastasis, they'll ask me to do a biopsy. But the goal here is to get the tissue. That's really that's what we need to kind of figure out what's going on. CT scanner, ultrasound. That's what I use to do biopsies mostly. This is what a biopsy gun looks like. It's not a gun at all. Doesn't even look like a gun, but it does make a clicking sound. And so basically you put in a needle in. This is our guide needle. And then through that guide needle, you put in the biopsy device. This is the biopsy device. And it takes a core of tissue. This is what that looks like. This is a CT scanner, patient on their belly. Our target is actually this guy right here. But if we're careful, we can navigate through all these really important structures between the big veins and arteries of the belly and get right at this target tumor, okay? So with careful planning, patient positioning, and as long as we're careful, we can plan usually a safe approach to get the tissue. This is what an ultrasound-guided biopsy looks like. And this is an ultrasound image of a tumor in the liver. And this big gray ball here is tumor, or right, black ball. And this is the needle going into the tumor right there. Okay. So it's outpatient. We usually give moderate sedation, local anesthesia, CT, ultrasound guidance. Can take as little as 5 or 10 minutes, sometimes a little longer if it requires some patient positioning. Usually it's a 2 or 3 hour recovery if it's like a liver biopsy, if it's because of risk of bleeding. But if we're not doing liver, it can be an hour or less. And we usually don't give any patients meds at discharge because they typically don't have a ton of pain afterwards. Sometimes they do. That can be an indication of bleeding, but usually they don't require much. So treatment, we're going to get into. So this is liver-directed therapy. So we're working up to this. So liver-directed therapies, basically, why are we concerned with these? Well, the liver metastases by themselves are a driver of mortality. You need your liver, okay? If liver metastases grow unchecked in the liver, then it can eventually result in liver failure. So if we can arrest the growth of liver tumors or make them shrink or somehow slow them down, then we can hopefully prolong life. So that's really the goal of liver-directed therapies, okay? And the liver as an organ is uniquely robust, it's durable, it can regenerate to a certain degree, and it means that we can beat it up, okay? So in the process of trying to slow down tumor growth or kill tumors, the liver can withstand some treatments that other organs can't. So this is where this is why we can do these procedures that we do. So there's 2 different types: transarterial, and which means we're going to go through the arteries, and then percutaneous therapies, that is thermal ablation. Okay. Goals of treatment would be tumor shrinkage, symptom control for patients with carcinoid syndrome, prolongation of life. So the transarterial therapies, there's really 4 kinds that we use. TACE, chemoembolization, is probably the most common one that I do. Bland embolization or just transarterial embolization, that's another common one. Drug-eluting bead transarterial embolization. We'll talk about this for a minute, but this is less common nowadays for patients with this tumor type. And then transarterial radioembolization, which we still do in some patients and frequently in other types of tumor, but we're doing it less and less, I think, in neuroendocrine tumors. So transarterial therapy basically works on a principle that all living tissues need a blood supply to survive. The tumors are no exception. They need a blood supply to survive and grow, and they get their blood from an artery in the liver called the hepatic artery. And there are many branches of the hepatic artery, but neuroendocrine tumors tend to be hypervascular, which means they tend to be greedy. They get a real rich blood supply. So if I inject medicine into the hepatic arteries that supply blood to these tumors, I can preferentially damage the tumor, okay? And I can stress the normal liver, but not to the same degree that I'm going to damage the tumor. Because the normal liver, it has an additional blood supply that the tumors don't have, okay? So we're working on that principle that these tumors are going to be sensitive to the medications I inject into that artery. So we use a small catheter. We usually insert it through the wrist, an artery in the wrist, or an artery in the groin, the femoral artery, and we navigate that up to the liver. And then we do something called an angiogram, where we inject dye into the arteries, and we image that with real-time X-ray called fluoroscopy. And then we can, once we're satisfied that our catheter is in the right position, we can administer medications to do damage to the liver, or excuse me, to the tumors, not the liver, tumors. All right, so liver is this organ here. Okay, so it's kind of up in the right upper abdomen. This is just a good anatomy picture of what the liver looks like. In the area that we're most concerned with, this is the hepatic artery. This is called the celiac artery. This is the common hepatic artery. This is the proper hepatic artery. And then the proper hepatic artery divides in the left and right, and it supplies different parts of the liver, much like a tree, okay? So this is where we work. This is where I work a lot. So this is what this looks like on an angiogram. So there is a catheter inserted up through the aorta, which is that large artery right here. So that catheter is inserted in the aorta, and then it's used to select the celiac artery, and then we inject dye. This dye looks black, but in reality it's just a clear liquid, but it does show up under X-ray Otherwise, a lot of these other tissues, they don't show up under X-ray. So we watch that dye flow through the artery, and we can see where we're going and what we're doing. So transarterial embolization is not a new procedure. It's not new. It's not exotic, but it's been around for a long time, actually about almost 50 years now. The first ones were performed in Japan. They didn't always know why it worked or how it worked, but they figured out that if they cut off blood flow to the liver by the hepatic artery, they could make tumors shrink. So over years and years of trial and error, they did, it's evolved to the state it's in now, which is much more sophisticated. We have great tools and catheters that they couldn't have dreamed of 50 years ago. But the principle is that we inject chemotherapy through the catheter, followed by an embolic material that reduces blood flow to the tumor. Okay, and chemotherapy is a term I think most of us can wrap our heads around. It's a medicine that kills tumor cells. We have a few that we use. I think most commonly it's doxorubicin in the United States. Sometimes it's combined with cisplatin, which is another chemotherapy agent, or mitomycin C. Chemotherapy is cytotoxic, damages cancer cells. Embolic material. So embolism is a term you guys may have heard before. To anything that's embolic means it's going to block off blood flow to something. So if you have a pulmonary embolism, that's actually a clot that has worked its way into your pulmonary arteries and is blocking off blood flow to the lungs. Okay, and that's not what we're doing. But embolic material means to block off blood flow. Okay. That's what embolism means. If you have an embolism in the brain, it causes a stroke. If you have an embolism in your heart, that's a heart attack. But I intentionally cause an embolism in the liver because number one, it'll tolerate it. Number two, it'll damage tumor cells. Okay. So if I can inject the chemotherapy, it goes to the tumor and saturates the tumor, and then I inject a medicine which slows down the blood flow and clogs up those arteries inside the tumor. And so I'm intentionally going to make that tumor ischemic. I'm going to deprive it of the blood it needs to survive. And so I'm going to hopefully damage it even more. Okay. So the goal here is shrink and kill tumors. There was a paper, I don't have a lot of data in my presentation on purpose, but I thought it was important to include this. This was about 600 patients that underwent chemoembolization in France, patients with neuroendocrine tumors, and they did like an 8-year follow-up, which is terrific. That's like enormous data. And so median time to progression, about 19.3 months. This is all patients. Median overall survival, 5.3 years. And they looked at responders. So those patients that their tumors shrank when they got chemoembolization, they lived on average 80.5 months, which is really good, versus the ones that did not respond. So if they got a chemoembolization and they didn't really respond, that portended a not as good prognosis, and they did not as good. But the therapies do work. So some limitations, anatomy, side effects, and then if both lobes of the liver are involved with tumor, which is pretty common, then we usually divide it up into 2 or 3 sessions, so we don't stress the liver too much. And we can do these as close as 4 to 6 weeks apart. Lopidol is an agent we use to help us do these procedures. We mix the chemotherapy with it. It's a very old contrast agent. It's over 100 years old. We're finding new applications for it. But this is what they started doing back in the 80s and 90s. They were using Lopidol, and then we kind of thought we could do better in the 2000s. We came up with some new materials that turned out they didn't work as well. So now we're back to using Lopidol, and so we still use it. This is what the Lopidol and the chemotherapy look like. It's called an emulsion. So you guys know what salad dressings are, oil and water mixed together. That's what this is. So we have a droplet of oil. This is the oil, this yellow material, and then each one of these little beads is chemotherapy. And we inject that into the artery. So this is a typical angiography suite. This is the one I use at Vanderbilt more often than not. This is what it looks like. The patient would lay here. This is the X-ray machine. I stand here, and then I can see what I'm doing by looking at this screen here, and then we have all kinds of other people in the room. But that's what it looks like when it's clean and free of people. So this is a patient that I saw in follow-up this week. So this is his pre-op MRI, pre-embolization MRI. So he's got these big hepatic tumors here. These are all neuroendocrine tumors. There. This is a really enhancing one. This one has some degree of enhancement on the inside, but he had many tumors in both lobes. So this is what his embolization looked like. So we did an angiogram, and his hepatic artery came off of an artery in the abdomen called the superior mesenteric artery. When you inject dye into that artery, it lights up this arterial tree, and we can see what the arteries look like inside the liver. And if we carry that out, we can see the tumor enhancement. So each one of these balls is a tumor. Okay. And then when I inject Lipiodol, it looks like this. These are these little balls of oil, and they'll flow through the artery, and they'll get stuck inside these tumors. And let's see if I can get this to go. Do we know how? Can we make this play? Do we know? Is there a way to do that? Okay, we'll skip it. This is going to show you what it looks like as these. Oh, no, it's going to play. Cool. Okay, that's what it looks like. So this is a different patient, but you can see these little balls of oil. It's a water and oil mixture of chemotherapy and oil, and that's what it looks like as you inject it. And it stains the tumor. So this is that very same patient. 4 to 6 weeks after we did the procedure. So this was his pre-embolization MRI, many tumors, and this is his post-embolization MRI. So each one of these, this is a living tumor, this is a dead tumor. You can see it shrank nicely, and then this enhancing tissue inside it is now dead. So all these little black holes are tumor. So dead tumor. So it works pretty good. We will we just treated his right side, and so he's going to come back next week, and he's going to have his left side treated. So he's got a living tumor there. So this is a living tumor, this is a dead tumor. Living, dead. He did great. So this response is what we're going for every time, and I would say it's more often than not what we get. Now, how durable it is going to be that is to say, how long is the response going to last is going to depend on a lot of factors. Patients with less aggressive tumors, their tumors are going to stay dead for longer. Patients with more aggressive tumors, their tumors are going to regrow faster. Because when you're doing these procedures, you're killing off big chunks of tumor, right? But realistically, you're not killing 100% of that tumor more often than not. Because each one of these cancer cells is like an independent entity, right? That's what makes them cancer. They'll grow irrespective of the other cells. And so if I kill off 95% of the tumor, that's terrific. That tumor is going to shrink down. It's going to have to start from zero, but it can eventually regrow, right? But in that period of time, we've hopefully bought folks time, if that makes sense. So that's one reason we do these. And then if they grow back and the patient's liver function is still good, which it usually is, we can do it again. So it is repeatable. So this is another chemoembolization, not one that I did, but basically showing the same thing, showing what it looks like as we administer this Lipiodol. It stains the tumor like that. That's a CT scan showing tumor staining. This isn't my case. This is just a case from the literature, but it's showing that this treatment works on big tumors too. So these are huge tumors. And you can see after chemoembolization, you can see how nicely they shrank down. And this bright white stuff inside the tumor is retained Lipiodol, so a retained chemoembolic material that is just there. And the chemotherapy is long since washed out and been metabolized, but the Lipiodol remains. And so you can see it does work on big tumors. So what to expect for chemoembolization? How am I doing on time? Okay. Anybody have any questions so far? I don't want to cut you guys off if you have questions. At the end? Okay, we'll do questions at the end. So TACE, what to expect? So you'll arrive in the morning. It's an outpatient procedure, but you may stay overnight. But you'll arrive in the morning. You'll be given, you'll go through pre-op. You'll go into a pre-procedure area. You'll get an IV. Make you take your clothes away and put on a gown. Unfortunately, do the things you normally do for a procedure. Most folks, all folks, will get octreotide to reduce the likelihood of carcinoid crisis. You'll get medications for nausea. Sometimes you'll get antibiotics. Different schools of thought on the need for antibiotics. And then moderate sedation and local anesthesia is typically how we do these. Because you don't feel me working inside catheters and the wires, you don't really feel that. You may start to have some upper abdominal discomfort as I do the procedure and the liver reacts. But up to that point, it's usually pretty comfortable. The most uncomfortable part of the procedure is laying on this flat table for a couple of hours. That's not very comfortable. So that's what the sedation is for. Most patients will fall asleep, but I can wake you up. So that's important. It's not the kind, this isn't like having to take out an appendix where you've got to cut on the patient. So most patients are not completely asleep with a breathing tube, if that makes sense. Occasionally we'll do it, but more often than not, it's just sedation. Procedures 1 to 2 hours, sometimes faster if things are simple. We use x-ray guidance, fluoroscopic guidance. That's another word for real-time x-ray. It's a 2 to 3 hour recovery, and then about half of patients will go home that day if they're feeling pretty good, and then the other half, if they're having side effects, which are common, which we'll talk about, they can be admitted for pain medication and nausea medication. Let's see. So post-embolic syndrome, it's normal following embolization of most solid organs. So if we're doing these procedures in the liver, it's what you see. If you do for the kidney in patients who have other types of kidney cancer, or kidney tumors, I should say, or bleeding, they have the same thing. If you do it in the spleen, they have the same thing. If you do it in the uterus for patients with fibroids, embolization procedures for fibroids, we don't use chemotherapy, but we're using the same principles of cutting off blood flow to an organ on purpose. It can hurt, right? It doesn't always, but it can hurt. So the body doesn't like it for a minute. So we have abdominal pain, nausea, fever. Those are all normal. Usually it's a low-grade fever. It's usually as bad as it's going to be like that night and the next morning, and then it starts to fade. And for some patients, it's not really bad at all. Some patients, they go home that day and they're doing good. But we don't really know how it's going to go for every patient. Some patients have to stay a little longer, stay overnight, And so once you've had one chemoembolization, it tends to be the same for subsequent sessions. So if you had, if you got to have a right lobe and then come back for a left lobe, it's usually the same how it was for you that when you had the right lobe. So transarterial embolization, this is without the chemo. So we do this for certain patients. It's favored by some interventional radiologists. There's not a ton of data, like head-to-head data between chemoembolization and bland embolization. There's reasons to do both. There is some data to suggest that if a patient is on Afinitor, you can add bland embolization, and they do well in patients with well-differentiated neuroendocrine tumors. And so I do that. If patients are on Afinitor, I'll just use bland embolization and keep them on their Afinitor, and that does work well. Drug-eluting bead transarterial chemoembolization. This was one of those things that we came up with in the 2000s because we thought we could do better than with Pyadol. I was in high school, so I didn't come up with this. But it does work, but it's fallen out of favor for lobar treatments nowadays, because there were some side effects, there were some complications, but it still can be used for more selective treatments. That is to say, not whole lobe, but just getting as close to the tumor as you can with your catheter and injecting the material there is still very safe. So this is a patient who's got 2 big tumors here, and they're fairly selective here, and they've injected the chemotherapy particles directly into the liver, into this supply of these 2 tumors. And then on the post, you can see that there's no blood supply. It's cut off. And then the tuber's just cut off and saturated with particles. So when you do it this way, it's still safe. So transarterial radioembolization, this is a therapy called Y90. Some of you guys may have had this. I do this sometimes in patients with neuroendocrine tumors, more often in patients that have other types of cancer. It works really well. But there's no data to say that it works any better than chemoembolization. So, and there are some limitations with it. So we don't do it as often. So instead of injecting chemotherapy, you're injecting particles that are radioactive. And they get stuck inside the tumors, and then they irradiate the tumors from the inside out. So that radiation causes damages living cells. It doesn't penetrate very far, so you're not glowing or anything. Once the little radioactive particles are inside the tumor, the radiation penetrates about 2.5 to a centimeter, 2.5 millimeters to a centimeter or so. So it's not gonna hurt other areas outside of the liver, if that makes sense. But yes, it does have some limitations. So it's not as repeatable. It can cause liver scarring over time. But we do use it in certain situations. So there's some good data to support using radioembolization together with Captum for G2 neuroendocrine tumors. That's relatively recent data. But Captum, has anybody in here taken Captum before? Yeah. So Captum is a radiosensitizer. So that means that patients on Captum, their tumor cells are more likely to be damaged by radiation than patients who are not on Captum. And so the idea is that if you're gonna make these tumor cells more susceptible to damage by radiation, and then you're gonna do a Y90, you're gonna fill the tumors with radioactive particles, and it's gonna damage the tumors even more than if the patients were not on Captum, if that makes sense. So this is one instance where I will use radioembolization. And then prior biliary instrumentation, when you have had a biliary stent, which a lot of patients have, the biliary tree, that is the bile ducts inside the liver, are always going to be colonized with bacteria that they wouldn't have otherwise been colonized with. And most patients do fine with that. They don't have any issues. But if you do a procedure like chemoembolization, there's a higher risk of infection. So, but not if you do, or it's less if you do a radioembolization. So we do use it for that patient, that patient population. And then if TACE doesn't work, sometimes it is reasonable to do a Y90. So this is a quick Y90 case. This isn't my case, but this is a tumor. It's a big white ball. It enhances. That's what it looks like on the DWI. This is on the post-contrast. This is the arteriogram. They've injected Y90 into that part of the liver, and it's white hot with radioactivity. This is a type of PET-CT. It's a type of nuclear medicine scan looking at where the Y90 went, okay? And we can see on the post imaging that it's just dead. So they get a good response there too. Could I have gotten as good of a response with chemoembolization? Probably, but radioembolization also works. So, there's, like I said, we have a lot of different tools in our toolkit. Percutaneous therapies. So these are other therapies you guys have probably heard of and maybe you've had. So these aren't through the artery, these are percutaneous. They're done through the skin. So ablation means destruction of tissue. So if you hear that word ablation, that just means to destroy, to ablate. And there's a few different kinds out there. There's microwave ablation, which is current state-of-the-art, very high temperatures, uses microwave energy to destroy a tumor. We'll talk about how you get that microwave energy into the tumor. Radiofrequency ablation, it's an older technology. Works fine, but the temperatures are lower, so it's kind of been replaced by microwave energy because we can get much higher temperatures inside the tumor with microwave. But RFA is very well studied, and it's what they do in a lot of the world where they don't have access to microwave ablation. And then cryoablation means to freeze. So we can actually create an ice ball inside of a tumor and kill tumors that way. We use it in other parts of the body like kidney and lung and bone and soft tissues, but we don't use it in the liver because of the risk of bleeding. Ethanol ablation, it's an older technique. They did this a lot in the 80s and 90s. It was less predictable, and that is literally where you stick a needle into the liver and you inject pure ethanol. And ethanol is toxic as can be. Whatever it touches, it kills. But as you can imagine, it's a liquid. It's thin, kind of runs everywhere. So you inject it into this tumor, and does it kill the center of the tumor? Probably, but is it going to kind of run between tissue planes and go in? Yeah, it can be messy. It works, though. And I think in good hands, it's pretty good, but we don't do it in America very much anymore. And then irreversible electroporation. It's super cool, but it's very time consuming. You put in 2 probes perfectly parallel into a tumor. You create a voltage across those 2 probes, and it can damage the tumor cell. It's just very time consuming, and so far has not been widely adopted. And then microwave ablation is the common one. This is, I think, the most common type of ablation that you'll see for patients with your tumor type. So we position a microwave ablation probe or an applicator or an antenna, depending on who you ask. We use ultrasound and CT to do it, and we park that probe right inside the liver or inside the tumor. And the goal is to cook a ball of tissue around that needle that also contains the tumor. And you can do it percutaneously, or you can do it surgically, where you cut open the patient and do it that way too. I'm a radiologist, so I do it percutaneously. So the goal is to ablate, destroy the tumor, and then a margin around it. And this is a graphic that kind of shows what that looks like. This is the antenna going through the skin into the liver. This is a tumor. This is, if you do this correctly, then the goal is to create an ablation zone which completely encompasses the tumor, okay? The entire tumor. So you probably need more than one antenna. So you probably need one up there, and you probably need one up there. But that's what we're trying to do. And so this is a machine that we use, but it gives you, basically it's not unlike a microwave. You set the power and you set the time. And it gives you a temperature. And the temperatures at the needle tip are, this one's 107, 120, 99. So it's very satisfying because you can hear the water inside the tumor vaporize. And you guys are asleep. It doesn't hurt you. You don't feel it, but it gives me some satisfaction to kill tumor. And we can see that on imaging. So this is one of my cases. I saw this patient in follow-up recently, and so this patient had a previous chemoembolization, and I don't know if that projects very well, but there's a little ball of dead tumor right here, and then tumor that is regrown right next to it. So that's marginal recurrence, which is not uncommon. This patient got a good response from TACE, but it grew back right there. And so this was really the only site of recurrence, and the arrows point to it. So that little white ball. All right. So this is what it looked like on CT. This is that retained Lepidol inside the previously treated tumor. And this little gray ball is the tumor. The new tumor, I should say. The regrown tumor. So on ultrasound, that looks like this. And when you stick a needle through it, this is my needle going through the skin, through the liver, directly through the tumor. And then when you turn on the machine, you get all this white right here. That is vaporized water. And so that's water gas, and it doesn't let sound waves go through it, so it turns into a white ball. And so it starts to cook from the tip of the needle back, and so we're about halfway through here, and so it's cooking right here and back. And so this is still tumor, but it's going to get back there. And so on CT, this is what that looks like. This is what the probe looks like, or the antenna going through the liver and into the tumor. This is that tumor right there. And that black ball right there, that's also air, gas, if you will, inside the tumor. Water vapor. And then on the post-contrast MRI, that's the ablation zone, completely encasing the tumor. And if we go back, can you see? Yeah, I don't know if this projects, but this is this little vein. There's a portal vein branch that runs right there next to the tumor. And portal veins carry blood, and so they're moving blood through that vein really fast. And so what happens is it doesn't cook that vein because it's carrying away heat right there. So you can actually see that vein. It's kind of cool. You can see that vein right there, still open, still patent, still carrying blood, but the tissue around it is all scorched. So kind of cool. I'm a nerd, and I enjoy doing these procedures, if you can tell. But I think you got to have doctors who like what they do. I do. I think that's important. So that's another microwave procedure. Similar sort of. This isn't mine. This is a case from the literature. But goal here, the same. Goal is to they did basically the same thing I did. Here's another one. Same sort of procedure, but I think we're running out of time, so I'm going to move on. This just shows what happens to these tumors over time. So this patient had an IRE, actually two different patients. They had an IRE. This guy had that's the irreversible electroporation. And you can see it kills this is the tumor here, it kills a big area here, but over time it just scars down. So patients can, like, well, what happened to the tumor? You kill the tumor, but it stays inside. It does, but the body you can say it just forms a scar and everything sort of shrinks down. So this is a microwave ablation. This is a tumor here. This is what it looks like right after I did it, or after somebody did it. But over time, it sort of shrinks down, and the area involutes and forms a nice little scar. what to expect. It's also an outpatient procedure. We'll give octreotide. We'll give antibiotics. You're under general anesthesia for this one because it can be less comfortable. And then the procedure time, 1 to 2 hours, 2 to 3 hour recovery. And almost everybody goes home for this one. They do really well. There's nothing that I'm injecting, no medicine that I have to inject. So usually don't have much in the way of systemic symptoms unless they have like a poor response to the anesthesia. Sometimes anesthesia makes folks real nauseous. But why don't we just do this on everybody? Well, it's not really, if a patient has 40 tumors, I can't, blast 40 tumors with this sort of technology because I'll destroy the liver. But if a patient has a few tumors that I can reach that aren't too central or aren't too hard to get to, then it's a fantastic tool. So there's some rationale as to who gets it and who doesn't. Sites outside the liver, we can do these procedures outside the liver in some cases. It's just very selective in how we do it and why we do it. This is cryoablation. We do this commonly for soft tissue tumors and bone tumors. Basically, you insert a special type of needle that instead of using microwave energy to kill a tumor, it actually generates a ball of ice around the tip of the tumor. So we use this. This is a patient who's getting a lung cryo. So these are the lungs. And so this is what the ball of ice looks like. And that ball of ice grows around the tumor and completely encases the tumor. And then you let it thaw for a minute, and then you refreeze it. And when it thaws for a second, it bleeds a little bit inside. And then when you refreeze it, that liquid that is leaked out freezes again, and you cause the cells to die. So anyway, I think this is it for time, so I won't go any more, but I didn't have much more to it anyway. I hope that was helpful, and thank you again for allowing me to speak, and if you have any questions, come grab me.